brief intro by way of some slides, and then we'll get to our phenomenal panelists here. I'm Keith Camhi, the managing director from Techstars for the Techstars Healthcare powered by Permanente Medicine Mid-Atlantic States Accelerator based in Washington, D.C. And I am absolutely thrilled to be joined by three thought leaders from Permanente Medicine who are going to be discussing trends in healthcare and how innovative startups can play a role in transforming care delivery generally, including specifically within their own system. And we'll get to introductions of the panelists in just a second. Before we do that, and I won't spend a lot of time on this, but just a one-slide overview of the program. There's a lot more information about this on our website, and in other recordings that we've done, we have an information session and other things that you can see on the website as well. But just to make sure to hit some key points here, this program is for visionary entrepreneurs who are meaningfully transforming healthcare delivery, making it more accessible, personalized, and efficient. And we're seeking solutions that could thrive in a value-based care environment to enhance patient outcomes, reduce costs, and improve care experiences across diverse populations. So broad charter of what we're working on, and if you can fit into a value-based care system and would benefit from getting some exposure to that, this program could be a fit for you. A few links, all of these are available through our webpage. So if you just search Techstars Permanente, will likely be the first link in there. You get to our webpage, but there you can see previous panel recordings. We had one yesterday and then a few weeks ago, and also a general information session, all linked there through the webpage, so you can watch those. You can see information about our new and improved $220,000 investment that we'll be giving to each company that makes it into the accelerator and what the terms of that are. That's basically, compared to past Techstars programs, it's more money on better terms is the headline of that. We get a lot of questions about whether your company could be a thematic fit for the program. And the best answer to that, if it's not otherwise clear from the general description here, the best way to take a peek at that is to go look at the link to Permanente Medicine Specialties and Institutes page that's linked on our website, and see if the solution you're working on would fit within one of those specialties. That'll be a good indicator that there might be folks here to work with you on what you're working on. Follow our LinkedIn page if you haven't already for updates and sessions that we're doing. That was yesterday's note, but that you're here, so you've presumably registered for this one already. And then finally, apply. The best way to find out if you're a fit is to get the application in. If you haven't already done so, there's about a week left in the application cycle, and that link is on the page. You're able to apply to 2 Techstars programs with 1 application. However, we'll tend to look at any that have this program as their primary option with our main focus. So if this is a fit for you and one that you think you'd be interested in joining, make sure that you have this as the primary, and don't leave primary and secondary blank, because it goes into sort of a more broad void. Leave it blank until you finish your application, and then fill in primary choice. Okay, so with that background, again, much more information on the website, and let us jump to our panelists. So with that, why don't we jump in and if we can start with you, Mona, just introduce yourself and your background.
Hi, everyone. Good morning. It's a pleasure to be here. I'm Mona Gahunia. I'm an infectious disease and internal medicine double-boarded physician, actively still practicing in both fields, and I'm the associate medical director for operational excellence. And what that means is that I develop new programs and initiatives in the system to address specific care delivery and patient needs. For example, I developed our memory care program and redesigned our wound care system. So just a couple of examples of the work. Thank you.
And John.
Well, pleasure, everybody. My name is Jon Treem. I'm the regional medical director here for palliative care, hospice, and supportive care services at MapMG. So think of my role as essentially clinical program development for serious illness and especially end-of-life care programs here in our network, and working on trying to make sure that the best and most innovative solutions are applied at essentially the most intense time in most people's lives. So really a pleasure to be here, and I'm excited to see all the enthusiasm.
Terrific. And Jessica.
Good morning, everyone. I'm Jessica Locke, Chief of Staff and Head of Strategic Innovations at MapMG, based in Washington, D.C. My focus in my portfolio is identifying forward-looking opportunities to drive both incremental as well as disruptive initiatives for our medical group that align with our long-term vision of ultimately providing value-based care to not only our patients that we serve, but also a great physician experience as well. I'm thrilled to be here today and looking forward to an engaging conversation on the future of innovation, as well as the impact that startups such as yourself can create for us. For the startups that are joining us today, whether this is your first AMA or you've participated in several, I'm particularly looking forward to today's conversation. In previous conversations, we've explored key challenges reshaping healthcare, rising cost, a shortage of healthcare professionals, shrinking margin, and the pressures of an aging population. So today we're going to double click on these themes and focus on the opportunities within primary care, a critical linchpin of the healthcare system, and the evolving role of palliative care in addressing complex patient needs. So again, I'm particularly looking forward to today's AMA, hearing from my esteemed colleagues that are on the call today, and engaging with your questions during the Q&A at the end of our session.
Terrific. Okay, this is going to be a fun one. And for those, so the waiting room was on right at the beginning here. So if you got here between a minute and 3 minutes in, you missed all you missed was the slide where I was going over the program background. So you can go see that on our webpage. That's that. If you were stuck in the waiting room for a moment there, just go to our webpage. Is the takeaway. Search Techstars Permanente, and you'll find everything I mentioned there. Or you can go back and watch the recording, and you'll see that repeated. So with that, I'm going to take down some slides and jump in just a second. I will say once again, my name is Keith Camhi. I'm the managing director of this program. I work for Techstars, and this is a collaborative effort between Techstars and Permanente Medicine in the DC area, covering Maryland, Virginia, Washington, DC territory. I won't spend a lot of time on my own background because there's more information on the website and in our first info session, but just briefly for those who I haven't spoken to before, I've been a founder for most of my career, mostly related to health and wellness, to the health and wellness spaces. I transitioned into supporting startups and investing in startups about 10 years ago, including the last 7 years with Techstars. I spent the first half of that managing our accelerator platform worldwide, so working in a lot of our partner programs and supporting the hiring of managing directors. My true passion is working with founders, though, so I left the dean's office for the classroom a few years ago to go run programs directly myself. But in that experience, in both experiences, I've gotten to work with a lot of so-called partner programs. And this one is truly extraordinary because our collaborative partner here at Permanente Medicine actively wants to work with the startups, roll up their sleeves, they're practitioners, and there's a lot of opportunity to get benefit from jumping right in and getting benefit from two organizations. So it's kind of a two for the price of one accelerator opportunity. By way of run of show, I'm going to go through some general questions with Jon and Mana to get rolling here, and we'll look at basically four things: just current opportunities for innovation and how startups can play a role in that. We'll look backwards at innovations that they've worked on in the past within the Kaiser Permanente system, Permanente Medicine, and how those have played out, just to get a sense of how that might work if you're fortunate enough to be part of the program. And then we'll look forward and take out the crystal balls and see in their areas where they see medicine going over the next decade or so, and how they would think about working with you if you were part of the program. I'm going to take down the slide deck here, if I can find the controls, which always hide under things. There we go, stop share. And then also for those who might have been stuck in the waiting room or joined late, there are two places where you can interact with us. Use the chat button to tell us where you're calling in from and what you're working on. And then also look at chat. We'll be adding some links in the chat session, including the webpage and other things throughout the session. Use the Q&A button at the bottom of your screen. to ask questions of the panelists. We'll be getting to those in the second half, and Jessica will be moderating that part. And if you can't see the Q&A button, it might be because your screen's not wide enough. So click the three-dot button, the more button, and you'll be able to get to the Q&A. All right, with that, let's jump into some questions. And why don't we start with current opportunities? So if each of you can give examples of challenges and resulting opportunities for innovation within your fields. And again, the description of the program is that it's designed for visionary entrepreneurs who are meaningfully transforming healthcare, making it more accessible, personalized, and efficient. With that in mind, what are some examples of the current challenges and resulting opportunities for innovation within each of your fields? And what kind of challenges would you love to see some founders working on? So Mona, if I can go to you first and have you jump in.
So more broadly, I cover all of adult and family medicine, and have been thinking about many different things. So one of the current challenges in adult and family medicine, or what we call, internal medicine, primary care, is co-management of complex patients with specialists, and especially as they transition care between hospitals, SNFs, outpatient, and the primary care doctor is supposed to be the quarterback of that care, but I don't think we still today don't have great tools for, seamless co-management, because the practice demands are so great. And then you've got to do all of that sort of on the side. So it's like an asynchronous job on top of, the daily patient care. So that's one general thing, but I'm going to go into a few specific areas, including within geriatrics. I think we all appreciate that we have a growing elder adult population with complex health needs. And within that space specifically, there's many different areas that we have to do really good broad screening and assessment. And we don't have great systems for that yet, specifically for cognitive decline. In addition to cognitive decline, which I could talk for a long time about, there is the area of mobility and balance that is really critical in the geriatric space. And not only fall prevention, but just general, how do you keep people active safely? So, and mobile and functional and able to do their ADLs at home. So that's another area. Also within the geriatric space, polypharmacy is a huge issue, and proper medication. We need more tools and resources for both our physicians and our patients around safe medication management. And then I'll try to move quickly. I'm getting through all of these different areas. The next area is lifestyle medicine and weight management. And in this space, we're doing currently a ton of work. We just formed a new center. But one of the challenges that we have is tailoring interventions specifically to individuals, and their individual needs, not just having, broad-based interventions that, we know that different things work for different folks, but how do you do that at scale? And then how do you continue to provide longitudinal support for behavior change? And then within, we're also starting to work in the pediatric weight management space. And that's even trickier because that's all family-based care. And you have to be really careful about not stigmatizing weight for children. So those are some of those challenges in that arena. And then I'll just talk about two more things and then hand off to Jon. One is wound care. So I mentioned before that I help lead wound care redesign within our region here. And one of the challenges that we have in wound care is timely reassessment of wounds to prevent dehiscence, to prevent osteomyelitis. Osteomyelitis is a bone infection which can cause many downstream effects, including limb loss. So that's a big area, that timely reassessment, good tools in the home to identify when wounds are deteriorating and getting that information back to physicians. So I'll stop there, hand off to Jon,
Thank you. Thanks, Mona. All right, so I'll start broad. I'll get narrow. I won't take up too much time, but what I'll say is like there's probably like a 2-day seminar of like 10 hours every day just talking about opportunities in the palliative care space, and we will still barely scratch the surface of what is needed in terms of healthcare delivery innovation in this space. So I'll give you some examples of things that we're working on, things that we really would love to partner on, but the truth is this is like a very open playing field. What I'll highlight for you is, and I do this with everyone, even though I assume that most of you are relatively savvy, when you think about palliative care, we think about this a little bit differently here at MapMG than I think other places do traditionally. Most people associate that with specifically end-of-life care and hospice. We think about this a little bit differently. So we really think about this as comprehensive serious illness management, right, for people with progressive disease arcs, right? So there is, an abundance of people with diseases that we know will arc towards increasing debility over time, right? Increasing need and dependence, more and more reliance on the healthcare system, and for a subset of that population, an arc that will result in end-of-life care and death. Right? And palliative care is really structured here specifically to deliver not just sort of traditional empiric-based medical care, but comprehensive care management for that population, right? So medical, social, psychological, behavioral, right? The things that are impacted by illness, especially serious illness, is really what palliative care is tasked to address for this patient population. So like I said, it is very broad, and generally speaking, in the context of healthcare innovation, an underrepresented field, right, when it comes to who is focusing on really improving the quality of care. So that's the general stuff. Narrower. There are some big things and major challenges here in this space, for partnership. Certainly, one of them is caregiver role and burden and support. So you might think of a disease as affecting an individual. The truth is it affects a community. And for people with improve or progressive disease arcs, that usually means increased functional debility over time, where more and more care falls on loved ones, caregivers, and the community, right? Because essentially, otherwise you got to come to a clinic, you come to a hospital. The care that's actually delivered is delivered in the home. And our ability to support the people doing that is actually very limited, and usually narrowed by constraints like literally like 20th century travel problems, like fax and communication, telephonic like things that like we think of as a little bit anarchic, but it's actually like the tunnel that you have to fit the train through. Right? We haven't widened the tunnel in a long time, right? So caregiver support innovations are critical in our space. The other thing I'll highlight is prognostic accuracy, right? So in order to deliver the right care to the right person at the right time, you have to be able to predict something with relative accuracy about their disease course. And if you guys don't know this already, clinical prognostication is really much more of an art than a science. And, for these people who kind of like get in the medical literature a little bit about things like positive predictive value. So how likely are you to be right when you give somebody, a prognostic outlook? The positive predictive values are actually it's like 25%. Those are the best tools we have, right? So the space of sort of like how can we actually deliver accurate information about the future to people who need to make decisions based on that information, right? Barely scratch the surface of what's possible in an area that's fully ripe for innovation. And the last thing I'll say is this, and this is a very broad thing, but I really want to emphasize it to this community because I'd be super excited to partner with anybody who wants to address this, right? But for those of you who don't know how end-of-life care works in this country, this is like, literally like a whole course in itself, but I'll distill it down to a few sentences. Generally speaking, it's based on the hospice benefit. The hospice benefit is a CMS-defined benefit for people who choose near the end of their life to get care focused on their comfort as opposed to on extending their life, right? For what it's worth, that was a benefit that was defined in 1982 by our government. Since then, 60 years later, there's been almost no modification to the benefit. And what that really means, right, is that we have not changed how we functionally address end-of-life care in about 60 years. And the way it's set up is as a capitated payment system. And really what that means is that the focus and the emphasis for essentially all hospice programs is cost containment, right? Because they get paid a certain amount no matter what, right? And what kind of care they deliver and what kind of care they don't is not value-based, right? It is solely a cost containment mechanism. And what that you can imagine that means is that the actual quality of the care provided is highly variable and really just dependent on the institution. Right. So the reason I'm saying it this way is for what it's worth, there's, I think CMS spent about $25 billion last year on hospice services. And no one has really come into the space to say we can do this better at higher quality with at the same or reduced costs using a newly thought through entirely different paradigm for how we deliver end of life care. And that is, it's the holy grail of my field, right? So, one, I think probably incredibly lucrative for people who figure out how to do it right. And two, is if you're like looking or interested in dedicating your life to something that will have the most important impact, right, in healthcare that, I think of, it's this space. And so, an area that's incredibly fertile for innovative design. Okay, sorry, and rent.
Don't be tired. That's amazing. And having recently experienced with in-law how broken it was, it's interesting to know why. So hopefully there are some folks working on that in the audience. But thanks both for sharing these. And I get excited by again, and these are just two of the many thought leaders at Permanente Medicine, and the range of opportunities to solve important problems here is extraordinary. So thank you for sharing that. Let's look backwards now. Let's just go in the same order. But if we can look back at some past examples of innovation that you brought into your system and how that played out, to give founders some sense of like, okay, so if I'm fortunate enough to get into the program and get to work with Permanente Medicine leaders, what might that rollout look like eventually? How do I get to a POC or a pilot and ultimately get to a contract to deploy? Where can it go from there? But let's go back to you, Mona, if you could start.
I'll start in the wound care space. So when we were redesigning our system, just to give you, you may have been on prior webinars where Jessica and Dr. McCarthy showed you kind of how we're laid out. We go from north of Baltimore down to Fredericksburg, Virginia, and we have 35 different centers. And at all of these centers, we have primary care, but we don't have specialists at every center. We have a hub and spoke model. So when we were thinking about our wound care redesign, we knew that we couldn't have a super specialized person in wound care at every center, and we needed to have a way to do a telewound consultation. And so we have a couple of NPs who are very specialized in wound care, and we have them now doing telewound, and they've been doing that for a couple of years now. And the idea behind this is that, a patient comes into primary care, they have a wound, the primary care doctor is not exactly sure, what stage the wound is, exactly sure how to best management. So they'll take pictures and give the clinical history and send it through our system to the NP. And this has worked really well overall. We've been able to triage these wounds better, get them to specialists when needed, provide management advice to primary care for wounds that don't need specialty care. But I think one area within this that could be certainly that we're looking to improve is those pictures that are taken and the measurements that are taken and the accuracy of that, because the NPs are basing a lot of their advice and decisions on those pictures. So certainly that's something that we're actively working on and looking for. So that's one area. So the innovation itself was that, new system that we developed, but we're still trying to innovate within it. And then I'll give maybe two more examples. One is in the lifestyle medicine weight management space. We run a diabetes prevention program, which we've ran for many years. But within this program, we have all lines of business, and including Medicaid patients who often are living in food deserts. And even though they're part of the longitudinal program, they can't really sometimes adhere to the advice we're giving about changing their diets because of their limitations with foods that they can access. So we partnered with an outside vendor to provide, and through a grant that we got from the Maryland Department of Health, to provide specific food delivery to some of these folks. And for the folks that we were able to seamlessly, engage in the program and outreach and make those deliveries happen regularly, it worked beautifully. And really, they were able to lose weight. They were much more engaged with us even after they finished the program, which is a 16 it's a intensive 4-month program, but it's a year-long program, 16 intensive weeks, and then follow up throughout the year. But we definitely had challenges there with outreaching that population because they can be difficult to reach sometimes, and the delivery of those foods. So that was another example. And then an area I didn't talk about earlier is pain management and opioid-sparing care, which is a huge area that I've worked on for many years, even before coming to KP. And in this space, we've tried a lot of new innovations and workflows, but I think one of our most exciting things is we launched a back pain e-visit. Back pain is one of the most common complaints in primary care. Probably most primary care physicians see it, 5 times a day easily. And so our whole initiative is focused on acute back pain and prevention of chronic back pain. So there's emerging evidence out there that if you address acute back pain at onset appropriately, you can actually prevent subacute and chronic pain. And that's so critical. So we launched this e-visit to have timely triage and treatment advice for patients, and then get them connected to the right next level of care, whether it's physical therapy, whether it's primary care, whether it's a specialist. So that's been going really well. And I think an area that we're continuing to focus and innovate on.
Sorry, John, how about you?
Perfect. So I'll highlight a few things. Again, I'll start a little bit broad and then I'll get a little narrow. But one of the things that I think has been a major challenge and a major focus for us here, with some successes but a lot of work to do, has really been around care plan coordination in a large health system. And what I mean by that is, one of the problems in, certainly American healthcare and everywhere, but, within any large health system, is how different people who are involved in the care, and they're usually an army of people, especially for people with serious illness, multiple providers, nurses, people in different contexts, in nursing facilities, in hospitals, in outpatient clinics, like the number of different people who touch a single person over the course of their illness, it's extraordinary. But how to actually make it so everyone rows together towards the same goal is actually an incredibly complex problem. Right? And so one of the things that we've really focused on here is how can we get better at communicating and evolving care plans together, de-siloing those care plans from clinical setting. Right. So instead of you go to a hospital and you develop a care plan in that hospital, and you go back to your outpatient doctors and that care plan, gets changed, and then you're in the SNF or you're at home and the care plan sort of like is moderated, and we're all just sort of tracking it through the EMR. But that one care plan is essentially like a center of truth, regardless of the clinical setting. That is something we think a lot about here. And one of the things that we, tried to do, just as sort of like a foot in the run, or sort of foot in the stream, or toe in the water, right, was to essentially develop a personal value-based communication flow sheet or device that's accessible across our clinical systems. And what I mean by that is, when you ask a person, right, what is important to them about their healthcare, what kinds of things do they want to focus on, what kinds of things would make a positive outcome from their perspective, right? Being able to record that so that anyone who touches that patient can actually see, right, the things that are highest priority for that patient is something we worked on and rolled out here essentially last year. That, I think is a an evolving topic, but I think something that we are really hoping, to continue to build on, to try to really coordinate the way that we apply care, especially for our most vulnerable patients.
Yeah.
The other thing I'll say is we did work on a serious illness algorithm here that is really kind of computer learning, large database, AI driven for prognostic purposes. And so, we developed a model internally for the purpose of essentially taking all the data that we collect, and we collect a lot of healthcare data, to try to define a patient population that we know is going to need increasing levels of support over time, right? And to define that patient population based to a certain degree on a prognostic outlook. I will say that model performs better than essentially every other clinical tool available, but still not what we would consider to be, have the highest sensitivity or specificity that we would want in a model like that, right? So something that rolled out in the last, 2 or 3 years, 4 years maybe, we call it our serious illness model. And I think is really kind of helping us drive how we want to approach, like how to find the right people for the kind of interventions that we're building, and a major focus in the last little bit as well.
Terrific. All right. Now let's shift to future focus now, and break out the crystal ball. And as I said to past panelists, we will go back and look at these in 10 years to assess how accurate you got these. But if you can predict where healthcare will be a decade out, like based on technology trends, current needs that you've been mentioning, hopefully what you're hoping to work on, and say how it might change for the better, and ideally what role founders might be able to play in being a catalyst of that change, and how MapMG could see working with people who are driving that sort of change, and what makes this your value-based care approach, your particular system, a uniquely good place to incubate such ideas. Broad question, but if you just forward look at where this might all lead to, and let's just go in the same order again.
Yeah. I mean, I think there's a lot of possibilities. I think, between AI and some of the current technology that we have for doing like telemedicine, combining the two things could just take things to the next level. For example, let's take that telewound example. What would be amazing is if, the NP who's receiving the telewound consult would actually get a summary of the patient's like clinical history, not just the little prompt that the physician types in as they're sending the referral, but like, through the chart, because a lot of these patients have prior history of wounds, and without having to dig so deeply into all of that. And then really, a next level would be like AI helping to generate personalized recommendations for that patient, because wound healing, for example, is a complex thing, and it really depends on so many factors: nutrition, if they're diabetic, all of these, factors are involved, vascular status. So just really bringing all of that into what currently is more of a simplistic model. So that's one big idea, and hopefully we'll see that happening. The other thing is related to that, and I was just talking with someone about this yesterday, is that a problem that we have, not just in wounds, but in general, is that, we have growing panels of patients with lots of different medical complexity, and we have some systems for tracking patients, but if a lot of people are not tracking their own health, and so you have to constantly follow up with them. So to have more automated systems for tracking and surveillance of patients. So let's say someone came into our urgent care with a wound, we took a picture, we put it in the system. It would be amazing to have sort of automated reminders and tracking that there's this patient out there with this wound. They may not come back in to see their primary care doctor until, their leg is falling off, but we should be calling them in, because we're prompted to do that. So that's another thing that I'm hoping we move towards. And then in the space where I think Jon and I's work overlaps a lot is home-based care. And especially for the geriatric population, there's just so many opportunities opportunities. And if I could focus on one thing, it's that polypharmacy and medication management. As someone who, still currently practicing in primary care, I can't tell you, it's so hard to know as a primary care doctor which medications your patient's actually taking at home, which is like such a simple problem. They may say they're taking it and you're making all these adjustments based on what you think is happening, but you don't know. So I think if we could have smarter pill boxes that really give us information back about whether a patient has dispensed a medication, taken a medication. Also, those could be linked to like remote monitoring devices that look at hypertension and glucose monitoring, and even inform a patient when they maybe shouldn't take a medication at home because their blood pressure is low or their glucose is low. So these are kind of the next level where we can go to improve safety, especially of the geriatric population at home. So I think I could stop there. And then I didn't answer the second part of your question. But I think in terms of working with folks here within Kaiser Permanente and MapMG, I think the advantages you get to directly work with physicians, get real world feedback and expertise, and I think that's, mentoring on, how we can together, overcome some of these challenges and test it out and pilot it in specific populations. So I'll hand off to Jon and I can come back with a few more things if there's time.
Terrific. And Jon, we'll have you answer that and maybe combine in how you would hope to work with companies in the program working on those. And then we'll get Jessica on here to moderate some questions from the audience as well. So one last reminder, if you want to get a question to the panelists, use the Q&A button at the bottom of your screen. You might have to hit more first to do that. And then Jessica will be on in a moment to get some of your questions to the panelists. But Jon, go ahead and take it away on crystal ball and engagement.
I would parrot a lot of what Mona just said. She took the words right out of my mouth. So, home-based care, I think, is a major way that we're hoping to sort of innovate in the next, near future. We should be able to do more and more sophisticated healthcare in a home setting. Hospitals are cost-intensive places. There are all sorts of problems that are associated with them: hospital-acquired infections, hospital-associated delirium, right? Things that probably actually aren't as conducive, especially to our cognitively fragile patient population, to exemplary or high quality care, right? And being able to move the technology that would allow us to safely care for someone in a home environment when we are not physically there all the time, I think is a major thing that we're hoping to sort of develop and see more of in the future. I totally agree that the problem of medication adherence is so simple and so hard, right? I prescribe a lot of opiates, right? End of life management of pain is a major part of my clinical practice, and they are very dangerous medicines if not taken exactly, right, essentially as prescribed. And our ability to understand whether that's happening is incredibly small. Right. So, these are just like small things, but I agree 100% with Mona. That's a space that we're really hoping to do better in. And then what I will say, just as a little plug for MapMG and for working in this accelerator, this is an incredibly facile organization. The most facile organization I have ever been a part of, really, meaning like most of the time in healthcare, right? Early adopters of healthcare technology are few and far between, and healthcare in general usually lags about 20 years behind the rest of like every other private sector when it comes to integrating, right, technologies. I will say that this is an organization that is incredibly data savvy, right, is able to sort of utilize and move on programs that develop and can demonstrate higher quality, better value, within, weeks, where most programs take years. So from the perspective of an accelerator, an entrepreneur, and a startup, you have a product, right? And you're trying to demonstrate the effectiveness of that product. I can't imagine a better place to be able to, play isn't the right word, but demonstrate, right, the effectiveness of your product than this organization. It has the patient population, right, that you need to be able to sort of access. It has the expertise, right, to help guide the clinical intervention, and it has the sort of flexibility, right, to integrate quickly. And if you're evaluating other programs and other places, right, in terms of where you want to be sort of piloting, I would strongly encourage you to ask hard questions about how rapidly, right, they can take a design or an innovation and actually apply it. Because I would guess that they would be challenged to do it nearly as well as this organization.
And what a great spot to wrap my section here. We'll bring Jessica on to moderate the audience questions, but I'll just say that from both my past experience as a founder for several decades, that is what I was missing as a founder. So that is music to my ears there. And now as a 7-year participant at Techstars and managing director, I think everyone out here can see why I'm very excited to be leading this program. This is an incredible opportunity between what Techstars, the strength of what Techstars can bring to companies in general, which I've seen for years, but then this addition of this collaboration, those are music to the ears of any founder. So that's fun. All right, Jessica, take it away with some audience questions.
So thank you so much, Keith. And I just want to say thank you again to our panelists for such a thoughtful and inspiring discussion. It's clear that we have opportunities ahead, especially in primary care and palliative care, but they ultimately require some passionate, bold thinking and meaningful collaboration. And I think that you can see the caliber of mentors that you would ultimately, get if you are part of our accelerator program to be working with these leaders here. So now we'd like to hear from all of you in the audience. We've seen some really great questions come through the Q&A already, and we'll do our best to answer as many questions as time allows. So we're going to start off with the first question to Mona. So how do you see opportunities to support patients in underserved areas like early stage chronic kidney disease, where many patients aren't even aware they have it?
Yeah, so that's a great question. I think within our system, we try to do, so we really try to do broad-based outreach and screening for anyone who's within our system. But I think that involves, really involves working with communities and community leaders. That's another thing that we go out and do. We use our mobile van and we do blood pressure screenings and we do flu shots. In Baltimore, for example, we have partnerships with barbershops and beauty shops to really find people where they are, where they're living, where they're working. We did this a lot through the pandemic with COVID vaccine education. We actually didn't want to be the ones delivering the message. We wanted the message to come from trusted community leaders. So really working with community partners for those specific populations that you're referring to, I think is key, beyond doing like culturally sensitive, outreach ourselves, which is something that we're always trying to do. I hope that answers the question, but.
It does. Thank you so much, Bo. So the next question I'll pose to Jon and to Mona, so whoever wants to answer this question. So how do you see value-based care evolving to include emotional support systems or non-clinical first responders?
I can certainly jump into that one. Okay, so that a large way to think about that is how you define value. Right. So, and value-based care, right? Like, we all want higher value, but what we actually say is value, is the crux of that question. So, it's a way of saying that I think increasingly what we are seeing is part of the value equation is patient-reported outcomes. So what a patient feels, right, about the benefit of their care, how well cared for they were, what kinds of things they were offered, how trusting they feel of their team, is increasingly a part of the value equation. And what I would say is from the context of emotional support systems, especially in a community context, being able to deliver care where someone feels wrapped, they feel like their needs are addressed. It's not just medical, right? It's emotional. It's the impact of illness. And they can report that they feel, right, more connected, more adhered to a treatment plan because of that additional support. That would make a major improvement in essentially what we would consider to be value. We are judged and monitored at all times, essentially around how patients feel about their interactions with KP, and that kind of innovation would be a major driver, right? So when it comes to like building a business plan, right? I know I'm sort of being a little far afield from the question that you're asking, right? But it's really about how is that innovation impacting the value equation from the healthcare system's perspective, and the value equation, you should know, is partially driven by patient-reported experiences, which I think is probably the major way you can impact that.
Great, thanks, John. Just one other question for you, John. So you talked a lot during the panel discussion about just wrapping around services, so making sure that not only the patient, but the caregiver and their community, right, is really involved in their care. So a question came through the chat regarding just unifying care coordination across different hospital or outpatient kind of care, or inpatient, right, care settings. Can you tell us just what was one of the hardest parts, to kind of coordinate all of that? And is there kind of a pearl that you can share with this group of maybe things that they can consider, right, with their ideas?
Oh, interesting. That's a really sophisticated question, and I'll try to be as concise as possible, but I'm happy to follow up individually to the asker. I would say that, if I had to highlight one thing, I would say that, the EMR is an incredibly powerful tool, but we don't talk a lot about the double-edged sword of the EMR, right? Which is that it is a tool that is almost by its nature designed to isolate a care experience, right, to an individual, right? Like, you saw this doctor, they wrote this note, they did this thing, it lives in the EMR alongside an entire history of similar interactions like that, right? But the history of the interaction is slivered. And it's this pancopia of like information whenever you open somebody's chart, and finding the most relevant information for the question and the moment being asked is actually like, it can be like searching for a needle in a haystack, right? So the point of that is that like the care coordination problems actually have to do with drawing the right information at the right time to put in front of the right person from this incredibly complex system that we call our EMR, right? And I can't actually understate how challenging that is. So I would say that like that's one of the things that I think we're constantly trying to improve on. It's one part of the challenge of coordinated care. Like I said, there are many, many more things to talk about, but that's one thing I would highlight.
It's a really good point, John. I think I would just add to that is that I think for the startups that are on the call, I think don't ignore, right, the importance of integration, right? I think if your solution, like in the short, obviously short term, right, you may not be like fully integrated into an EMR, right? But in the long term, right, if your solution doesn't work within an EMR, right, or fit into clinical workflows, so that it's easy to do the right thing at the right time at the right place, it's probably a solution that won't last. So that's just something to kind of consider, as you're thinking about, your strategy. So the next question is to Mona. So this is related to neurodegenerative care. So is non-screen engagement undervalued in brain health today? How do you see tools, this like cognitive games or puzzles, fitting into future of dementia care?
First part of that question was what though?
So is non-screen engagement undervalued in brain health today? How do you see tools like cognitive games or puzzles fitting into the future of dementia care?
So I think it actually fits in today. So as we created our memory care program, which we started that journey back in 2016, 2017, but prior to that, our patients were going to neurology, which is, neurologists can certainly diagnose dementia and manage dementia, but we actually created a program with geriatricians because we wanted to provide more holistic care to not just address the cognitive needs, but the whole person needs. And all the other syndromes of aging, along with the cognitive decline, and also provide really good caregiver support. So in our program, from the beginning, the caregivers are involved, and they actually get to meet one-to-one with the physician. And part of what we we've actually worked with a bunch of different outside companies, including Brain HQ, which does online brain games, and has a lot of evidence base. And so we actually made Brain HQ available to all of our Medicare patients as a benefit. And then we're working with another company, and now I'm like blanking on the name, but I can picture the book that we actually have a book that we give away to all of our patients to do math, reading, it's math, reading skills, writing skills. So it's not exactly what you're saying, but we promote also, our physicians are really good at counseling on other things you can do to keep your brain active, like puzzles and the research in this area is constantly evolving. It used to be that puzzles were the big thing, but the latest thing I've been reading is that it's actually doing something new and pushing yourself to do something a little bit new. So whether it's cooking a new recipe or, something like that. So hopefully that answers your question. We actually really are thinking outside of the box we're not just doing medication management for dementia care. We're really trying to use all of the tools to slow cognitive decline.
Great, thank you, Mona. So again, this question is to Mona. So we've talked a lot about just the opportunities within our aging population and our sickest population as well. But what is your perspective on the growing trend of younger individuals seeking DIY healthcare solutions that bypass primary care physicians, especially when it comes to lab testing and preventative services? And I think, obviously at Kaiser Permanente and Permanente Medicine, we care about all of our patients, right? So the same kind of focus that we have on our aging population, we also want to make sure that, our healthy, younger kind of population are also receiving, value differentiated care. So can you talk a little bit about, what we're doing for that population?
Sure. And I remembered the name. It's funny that I couldn't remember, and I'm talking about memory care, but it's Stronger Memory is the name of the company that we've been working with, and the book that we give to our patients. So that's the name of that. So Stronger Memory and then Brain HQ were the two outside companies we've worked with. So in terms of our younger patient population, so this is like Jessica, this is an issue we've been thinking about and struggling with for many years, and I think we've come up with a decent balance. I think and as someone who practices both ID and primary care, what I see with the risk of that kind of episodic care, whether it's through an e-visit or telemedicine, is that it's just that, and that the problem is that nobody is putting together the bigger picture when you have a recurrent problem. So yes, we should be providing platforms for quick, convenient care like e-visits. We have grown our e-visit platform tremendously over the last, 5 years for things like a quick STI screening, for example. Also for URI, Tamiflu, even Paxlovid. We have all of these like quick visits for something that you need. But if you're having, I think what folks need to understand is if you're having a recurrent problem, a chronic condition, episodic care is not the way to go, because you'll be seeing different doctors, you'll have different practitioners weighing in, and you won't have that continuity. So actually have an example of this. Like I saw someone in primary care a few weeks ago who had been seen in urgent care, had pneumonia, and she's a young person, but I'm still following her because although she's recovered, she's finished with her antibiotics, she's still having some issues with her respiratory status. So it's like if she had just gone to urgent care and then gone back to urgent care, that would have been okay, but nobody would be like following her longitudinally and, helping address each issue as it comes up. So I think that's the challenge. I think it's having those platforms there, but then also knowing when to kick people out of those episodic venues into more longitudinal care is important.
Thank you, Mona. So, I think we've heard from the panelists and through the discussion today that, while we're casting a really kind of wide net in terms of applications and areas of interest, we're really looking at every application and taking into consideration, will it fit within our value equation, right? Quality plus patient experience plus physician and staff experience over cost. So I'm going to turn it back over to Keith so that he can just maybe answer the final question, which is, how is Techstars Network able to navigate the legal hurdles that surround some of these issues we've discussed within the healthcare industry? Do founders have to demonstrate success around regulatory hurdles in order to be a candidate, or will Techstars be able to provide help? And I think one of the things that we'll be able to provide help on is the clinical mentorship that we talked about, right? Being able to pilot or POC, within that value-based care system on a very diverse population of patients. But Keith, can you talk from Techstars' perspective, right? How Techstars will help with just the startups navigating some of these complex systems?
Perfect. Yeah, and maybe I'll use that as a segue into a little broader as well, which is to say, we've been focusing in on these thought leader panels on the clinical related support you'll get by way of the collaboration between Techstars and Permanente Medicine, which is extraordinary and unique among Techstars programs. I've taken a little bit for granted that you might know about what Techstars does in absence of a collaboration like that, and so you'll get both and. So as part of what we do, we consider Techstars, we have great core content and things to support every founder, but in addition, we consider it a curated mentor-based journey through your startup experience, both within the 3 months of program and hopefully beyond that through Techstars for Life. So we surround each program with on the order of 100 mentors. A good number of them will come from Permanente Medicine, and then a good number come from all different areas that support startups in their journey: financial, marketing, sales, co-founder dynamics, and legal. Importantly, we'll have a number of law firms who get directly involved and specialists who've done it from the founder seat as well. So while I can't, we don't have on staff a legal regulatory expert, but we surround the program with a lot of expertise that'll be unique to what the program's needs are. So hopefully that broadly answered the question. And we're Jessica, I don't know if you had anything else to close out, but
No. I mean, again, I think this has been, I've been here for nearly 2 decades at Permanente Medicine, and just hearing the conversation today, I'm more inspired than ever, in terms of kind of what lies ahead. I know that these are really complex challenges, but I think between, the collaboration between Techstars, Permanente Medicine, and startups, such as yourself, I think we can really change, the world in terms of how we think about, delivering, value-based care to some of the most vulnerable patients, but also, the how do we keep, patients living longer and healthier lives. So thanks so much, everyone, for participating today. And we look forward to hearing from you. Again, applications close on June 11th. So please make sure that you fill out the application, by that time. I'll turn it back over to you, Keith.
Perfect. No, John, Mona, thank you for doing this. Jessica, thanks for leading on all things regarding the collaboration, and for the Q&A. Audience, thank you for joining us for this. And once again, one last plug for get your applications in on time. And this is, I'm excited. I get more excited every time I get the chance to have one of these conversations, because this is a great platform for anyone working in startups to advance what you're doing. So this is going to be a lot of fun and a very meaningful program. So thank you for joining us, and hopefully we'll be talking to you soon.